Urban legends and myths.
There are many urban legends or myths regarding withdrawing and withholding. The conventional wisdom was that it was more difficult to withdraw treatment than to withhold it in the first place. This is the ethical problem. If someone has something, can you really take it away? Emotionally, we feel less able to take something away once we have given it out. Morally and ethically, however, there is no distinction. It's acceptable to say this is not doing what we intended, and thus we have to take it away. Likewise, you can always look down the road and say whether or not this would be a good thing or not according to your medical expertise and experience. If it isn't, then you can always withhold it.
Withdrawing versus withholding.
Another urban legend is that if you do nothing, you might be the cause for a person's death. Withdrawing, in contrast to withholding, was seen as killing the patient.
Why are there legends and myths?
There are several reasons why these legends and myths persist. One is loyalty to the patient. Some people feel fiercely loyal to their patients and will try anything to save them because they view death as the enemy. Another is sometimes we do things not for the patient, but in order to show the family that one is doing, quote, everything possible. The third is we live in a culture that likes to deny death. And fourth, there's the misconception that the law requires maintaining life-sustaining treatments. Make sure you are informed of the law before you practice. Very rarely is there a law that says you must maintain life-sustaining treatment, especially in situations where benefits do not outweigh the burdens.
Withdrawing and withholding. Ethical guidance.
So let's talk about some ethical guidance in these situations. If a treatment is not effective or beneficial, there is no moral obligation to continue it. The way you do this in communication is to reinforce the goals with your patients. How you phrase the goals can be very important. When you reach a point where the patient has been overmastered by their disease, the focus needs to change from prolonging life to providing comfort. To use another quote from my nurse practitioner wife, Christine Biggie, she likes to make the change for when you want to move from prolonging life to providing comfort in terms of fighting for your patient. What she says is we're always going to fight for our patient. What we fight for might change. In this case, they're going to change from fighting for a cure to fighting for a good end or to providing comfort. And one of the reasons is often continuing aggressive treatments, such as mechanical ventilation, may cause discomfort without producing any compensating benefit for the patient. In those cases, you should consider if the goals of treatment are being met. In some cases of caring for dying patients, withdrawing burdensome treatments is just as important as withholding aggressive treatments like CPR. Medical futility.
We sometimes use the language of medical futility to describe instances where an intervention will not have its intended effect. For a complete discussion of the senses of futility, please refer to podcast episode 11.
Medical futility. Disguising uncertainty.
One of the things to avoid, however, is using medical futility to disguise your uncertainty, and that's because it's unethical. You should have some certainty about the things that you are proposing to a patient, and if you study the literature, you shouldn't be uncertain. But what you don't want to see is someone who uses the futility aspect to undermine the fact they don't know what is going to happen and are using this to avoid discussions.
Respect advanced directives.
So there are 4 guidelines to consider when withholding or withdrawing treatment. First is advanced directives. If a patient has an advanced directive, we should try as clinicians to respect that. But what you have to ask, can a family override that advanced directive? And sometimes they can. If they try to, it is a red flag and is a signal that more discussion is needed. There should be a discussion about what the patient would have wanted, and if you can ascertain that this decision was made a long time ago or not in the right frame of mind, you can override it. In general, though, you should always respect it.
Use a benefit burden calculation.
The second thing to consider is a benefit burden standard. Calculate the benefits and what the likely burdens are, and if you end up with more burdens than you do benefits, you might want to consider withholding or withdrawing treatment. On the other hand, if benefits are greater, it is ethically appropriate to continue.
Disclose poor prognoses and futility.
This consideration is about respect and autonomy. Don't withhold disclosure from patients and families where there is futility or poor prognosis.
Treat until disputes are resolved.
Let's say there's a huge dispute about treatment. You have family coming out of the woodwork wanting one thing that conflicts with what the patient said or his advance directive. Maybe you live in a state where you have a clear and convincing evidence standard. What we don't do is say, we don't care about the argument, we are just going to do what we feel is best. What we do instead is say, we are going to maintain treatment until we can resolve this issue. How to use advance directives.
One important thing is that advance directives do not always trump a benefits burden assessment, so you should still do the benefit burden assessment. Let's say someone has a directive that wants everything to be done, but the benefits and burdens assessment says that almost everything will be ineffective and more burdensome. That is when you need to sit down with either the patient or the patient's surrogate to explain things. This may be a situation where you need to override the advance directive because the patient didn't know what they were getting into. If the patient or the family still insist on, quote, doing everything, at most institutions there is a way that when you get two physicians to certify that what the family is asking is medically futile, that is unilaterally saying we are not going to do those things. I have seen very few people willing to actually do this, but it is ethically justifiable. Very few clinicians will decide to do this because it is considered very controversial.
Guidance on using the benefit burden standard.
When you do use the benefit burden standard, there are two types of benefits to keep in mind. There are health benefits and there are quality of life benefits. So if you add days or months to life that is mutually beneficial to the patient and others, that is a good thing. If you can improve their mental status, that is also a good thing. And if you can cure the disease, that is good, but also know that these things should be separated into two categories, health benefits and quality of life benefits. The same guidance goes for the burdens. When treatments will not provide any noticeable health improvement, that's a bad thing. And when treatment diminishes quality of life, that too is bad. These two types of burdens work in tandem within the standard. To summarize, an ethically sound basis on which to evaluate choices to forego life-sustaining treatments in incapacitated patients is to assess the benefits and burdens for each patient for each treatment. The following guidelines are suggested. Clinicians have a duty to make recommendations to other decision makers based on these benefit burdens assessments, and the benefits and burdens should be assessed within the framework of the patient's prior expressed wishes or known values, beliefs, and previous decisions about treatment. And a substitute judgment is the standard that we're looking for the surrogate decision maker. If it's not possible to make that substituted judgment, then the best medical interest standard should be followed. In addition, family members are usually the best source of information about the patient's preferences. That should be supplemented by information from members of the clinical team. In addition, when the benefits of treatment are proportionate to or exceed the burdens, it is obligatory to give treatment, unless it's been refused by the patient in their advance directive. And finally, it's obligatory for clinicians to withhold and strive to withdraw treatments that clearly will harm or are harming the patient.
Treat until disputes are resolved.
If we have a situation where we need to treat a patient and disputes evolve during that process, there are some guidelines for the situation. If you have a surrogate of an incapacitated patient and they are demanding any of the following things on the slide, here are some guidelines for what you need to do. Withholding beneficial treatment that the patient may have wanted, clinicians should not acquiesce to this demand. You should say this is something the patient explicitly said they wanted, and you have questions about why the family is disagreeing. If you have your benefits burden assessment done and you know it's something that will be very burdensome, but the surrogate still wants it, that's a red flag. Clearly harmful treatment, this too should also be a red flag.